Welcome to the deep dive. Today we're tackling Klinefelter syndrome, a really quite common condition in males, but one that often flies under the radar. Think of this as your essential briefing.
Exactly. We've taken some comprehensive revision notes and basically boiled them down to the absolute must-know info. Our mission is simple: high-yield facts, easy to grasp, easy to remember.
All right then, Klinefelter syndrome. Let's get straight into it. What exactly are we talking about?
So at its core, Klinefelter syndrome is a genetic thing. It's where a male is born with an extra X chromosome. So instead of the usual XY, they have XXY.
XY, okay.
Yeah. You might sometimes see it written as Klinefelter syndrome or maybe 47 XXY karyotype. And this extra chromosome, it causes differences, physical ones, developmental, sometimes behavioral too.
Okay, so where does this extra X come from? Is it like passed down in families?
Generally no. The cause, the etiology, is usually just a random mistake when sperm or eggs are being formed. It's a process called non-disjunction.
Non-disjunction.
Right, the chromosomes just don't split up correctly. So it is genetic because it involves chromosomes, but it's not typically something you inherit from a parent.
Got it. Are there any factors that, make it slightly more likely to happen?
Well, the main one mentioned in the notes is advanced maternal age at conception. That seems to slightly increase the risk, but it's often just a random event.
Okay, so the extra X is there. What does it actually do to the body, the pathophysiology?
Yeah, the key thing is how it affects how the testes develop. That extra X interferes with their normal growth and function.
Ah, okay.
And the main consequence of that is reduced testosterone production. Significantly reduced, often.
Right, testosterone.
And it's really that lower level of testosterone that drives a lot of the characteristic features you see with Klinefelters, the physical stuff, the developmental aspects. Testosterone is so crucial for male development, so less of it makes a difference.
That makes sense. So if someone presents with some potential features, what else would be on the list? What's the differential diagnosis?
Good question. You've got to think broader initially. Other chromosomal conditions maybe, like Turner syndrome, although that's mainly in females, it's still a chromosome issue. Also, various hormonal imbalances or other things that affect how male sexual development happens. There can be overlap in symptoms. But ultimately, genetic testing, that karyotype, is how you get a definitive diagnosis.
And the notes mention quite a lot of associated conditions, almost like a wider differential picture. Can you run through some key ones?
Yeah, it's quite striking how widespread the effects can be. Endocrine-wise, you see more diabetes, more hypothyroidism, also things like empty cellus syndrome, hypoparathyroidism, sometimes even precocious puberty. Then there's bone health osteoporosis is a bigger risk, which can even lead to things like vertebral collapse. And interestingly, even teeth can be affected, something called toroodontism.
That's quite a range already. What about other systems?
Well, there's a higher chance of autoimmune conditions, lupus, rheumatoid arthritis, Sjogren's syndrome. Cancer risk is another area. We see more germ cell tumors. And notably, male breast cancer risk is higher, particularly in individuals with mosaicism, the 47XY form.
Right, mosaicism meaning some cells are XXY and some are XY.
Exactly. There's also an increased risk for blood cancers, leukemia, lymphoma, myeloproliferative diseases. Cardiovascular disease is more common too.
Like what specifically?
Things like DVT, pulmonary embolism, venous ulcers, varicose veins, even mitral valve prolapse. Lung disease like chronic bronchitis is also seen more often. Developmentally, speech delay is common, and there's a link to a broad range of psychiatric conditions, including autistic spectrum disorder. It really shows how fundamental that one extra chromosome's impact can be.
It definitely sounds far-reaching. How common is it then? What's the epidemiology look like?
It's actually the most common sex chromosome disorder out there. The prevalence is around 1 in 660 men.
1 in 660, that's quite high.
It is, but what's really notable is that many individuals go undiagnosed, often right into adulthood. The signs can be subtle or variable.
Okay, let's get into that clinical presentation then. What are the signs and symptoms we should be looking out for?
It can vary with age, but some features tend to stand out. Symptoms often include being tall, quite tall stature. We use the mnemonic King Kline, think King for tall.
King Kline, okay.
Tall. Infertility is a major one, often the reason someone seeks medical help in adulthood. Less facial and body hair than expected. Gynaecomastia, which is enlarged breast tissue.
Right, the man boobs is sometimes crudely put.
Exactly. Learning difficulties can be present, sometimes delays in speech and language development. Social and behavioral challenges might emerge too. Sometimes there's a rapid growth spurt in mid-childhood, a tendency towards weight gain around the middle truncals, obesity. And in adults, hypogonadism is key. The testes aren't functioning fully.
And what about the signs a doctor might pick up on examination?
The classic sign, really crucial, is small, firm tests. That's a big clue. You might also see a lack of the usual secondary sexual characteristics developing during puberty. Gynaecomastia, as we said, which also carries that slightly increased risk of breast cancer you need to be aware of. And if you do hormone tests post-puberty, you typically find high gonadotrophin levels, that's LH and FSH, but low testosterone. The brain's shouting, but the testes aren't responding properly.
So just to pull those clinical features together from memory. Tall King Klein, often infertile, small test, gynecomastia, maybe some learning or speech issues. And the notes also mention fatigue, muscle weakness, metabolic syndrome.
That's a good summary of the common picture, but it's also really important to stress that sperm can actually be present in over half of cases.
Oh, really? Over 50%?
Yeah. And individuals with that XYXXY mosaicism might even be fertile. So this variability, it really contributes to why it often gets missed or diagnosed late.
Yeah, I can see that. What makes diagnosis so challenging sometimes?
Well, the sheer range and subtlety of symptoms is the main thing. In young boys before puberty, the signs can be really minimal. Same for those with mosaicism. Small tests and infertility are strong indicators later on, but they aren't always obvious or the presenting issue. You might get neonatal clues like a micropenis, hypospadias, undescended tests, but they don't always trigger the investigation for Klinefelter straight away.
Okay.
Sometimes puberty might just seem a bit incomplete or delayed, easily missed. And often, it's not until complications pop up later. Metabolic syndrome, heart problems, maybe breast cancer, or even significant anxiety or depression that someone digs deeper and the karyotype reveals the answer.
So when suspicion is raised, what investigations confirm it?
Genetic testing, that's the absolute gold standard. A blood test for karyotyping looks directly at the chromosomes.
Karyotyping.
And, during pregnancy, prenatal diagnosis is possible via amniocentesis or CVS if there's a reason to check. Hormone tests are also really useful, especially after puberty, that pattern we mentioned. High LH, high FSH, low testosterone, hypergonadotropic hypogonadism.
But usually normal before puberty.
Often normal before puberty, yes. So the chromosome analysis, the karyotype, that's definitive, especially if those gonadotrophins are off. Semen analysis is obviously important if infertility or hypogonadism is a concern. And then, once you have the diagnosis, you screen for those related health issues, diabetes, cholesterol, bone density, etc.
Okay, diagnosis confirmed. What does management involve?
It really has to be a team effort, a multidisciplinary team, or MDT. You'll typically want an endocrinologist involved for hormones. A geneticist can be helpful for counseling, explaining the condition, psychologists for emotional or behavioral support, and often physiotherapists, speech therapists, occupational therapists, depending on the person's specific needs.
And treatment-wise, testosterone replacement seems central.
Absolutely. Testosterone replacement therapy, or TRT, is a cornerstone. It's usually started around the time puberty would normally begin. Well, the goals are twofold. Try to reduce some long-term health complications and also help promote more typical physical development, muscle mass, hair growth, and psychological well-being, things like mood, energy levels, libido. It basically aims to restore testosterone to normal levels and helps with bone density too.
And what about the infertility aspect? Are there options there?
Yes, there are. For some, fertility treatments like ICSI intracytoplasmic sperm injection might be possible if sperm can be retrieved.
Okay.
Artificial insemination using donor sperm aid is another route. And if gynecomastia is significant and causing distress, plastic surgery, a reduction mammoplasty can be considered.
So beyond the TRT and potential surgery, what other supportive management is key?
That's where the rest of the MDT really comes in. Speech and language therapy if needed, occupational therapy for coordination, physio for muscle strength.
Right.
An infertility specialist is obviously crucial for discussing family-building options. Psychological support, counseling, maybe behavioral therapy can make a huge difference for coping with any social or emotional challenges.
And the surgery for gynecomastia, when does that usually happen?
Typically considered after starting TRT once hormone levels are more stable. And for infertility, beyond ICSI and donor sperm, there's sometimes a technique called microTES, microscopic testicular sperm extraction, to try and find sperm directly in the testes. Adoption is another important path for some.
You mentioned sperm retrieval. Is sperm banking ever considered?
Yes, sperm cryopreservation is sometimes discussed for boys around puberty before testosterone levels fully decline or treatment starts. But the data on how successful that is long-term in this group is still a bit limited. The overall aim of management is really holistic, address specific symptoms, maximize health and well-being, provide educational and social support.
So putting it all together, what's the outlook? The prognosis for someone with Klinefelter syndrome?
The key message is that with good management, with that multidisciplinary support, individuals can definitely lead full, productive, fulfilling lives. Early diagnosis and intervention for any developmental or health issues really helps.
That's positive.
It is. However, we do need to acknowledge that the condition is linked to increased morbidity, more health problems, and potentially a slightly reduced lifespan. Maybe around 2 years less on average. This is largely due to that higher risk of mortality from some of those associated conditions we talked about.
Which brings us back to complications. Just to reinforce, what are the main ones to monitor for?
Yeah, it's that increased risk profile.
Yeah.
Osteoporosis, metabolic issues like diabetes and high cholesterol, cardiovascular problems, certain cancers, especially breast cancer and some blood cancers, regular monitoring, proactive health checks, managing risk factors like weight and blood pressure, guided by their healthcare team. It's all really important for mitigating these risks. Awareness is key.
This has been incredibly informative. So to quickly recap for everyone listening, Klinefelter syndrome is genetic. It's XXY in males, often leading to low testosterone. Remember, tall King Klein is infertile, has small tests and man boobs, Gynaecomastia, and sometimes struggles with learning and speech for the key features.
Good mnemonic.
Diagnosis is confirmed by karyotype, genetic testing. Management needs that team approach, with TRT often central. While there are increased health risks to manage, the outlook with good care is generally positive.
Absolutely. It really highlights, how important it is to understand these genetic variations and support the individuals affected throughout their lives.
A perfect summary.
Yeah.
And if you are revising or want to learn more in this high-yield style, do check out forMSRA.com and also freeimpasra.com for great resources. Thanks for joining us for this deep dive.